Dr. Mashfiq. It was really wonderful to know about the various endoscopic procedures that have been done in a government medical hospital setting amidst all the limitations. Very well done. Now, our next speaker is Lieutenant Colonel Dr. Mohammad Nasiruddin, a very brilliant surgeon who received the gold medal from Bangladesh College of Physicians and Surgeons. He will talk about the idiopathic ascites after laparoscopic appendicectomy, review of literature, and a case report. Dr. Nasir.
Thank you, Professor Samia Mubin, and congratulations for your great achievement. And Bismillah Rahmani Rahim, respected chairperson, moderator, my teacher, senior and junior colleague, I, Lieutenant Colonel Nasir, welcome you all to my two presentation. এবং সবাইকে মুজিব বর্ষের শুভেচ্ছা। Next few minutes, I will talk about idiopathic ascites after laparoscopic appendicectomy and review of literature, and I will present a case report. This is my CMH, Dhaka, where I am working as a classified surgical specialist and associate professor and laparoscopic surgeon. And I thanks to my guide and moderator, Brigadier General Shahinur Rahman. He is professor and advisor of thoracic surgery and head of the Department of Thoracic Surgery. Minimal access surgery is gold standard for many surgical procedures. Unexpected and unexplained complications are encountered by the treating surgeon. Development of ascites after laparoscopic procedure is very rare. It is distressing situation for a surgeon and it is demoralizing for a patient. And so our aim of this presentation, we will present a case of idiopathic ascites after laparoscopic appendicectomy, and we will review the literature and try to find out the similar case report and understand the cause and management principle of this type of patient. So my patient was Master Doha, a 10 years Bangladeshi boy, presented to me with a feature of acute appendicitis with pain and fever for 2 days, clinically pain in the right iliac fossa and maximum tenderness over the McBurney's point. He's febrile, temperature 100 degree Fahrenheit. He also complained anorexia, nausea, but no other comorbidity. And his BMI is 16 kg per meter square. He was admitted in a private hospital of Dhaka, Bangladesh, clinically as a case of acute appendicitis. And his preoperative routine investigation shows normal except neutrophilic leukocytosis. So he is planned for emergency laparoscopic appendicectomy. The operation were conducted under general anesthesia with 3 ports, one 10 millimeter supraumbilical port, one 10 millimeter left iliac fossa, and one 5 millimeter port in the right subcostal region. Diagnostic laparoscopy was done, and there is no free interperitoneal fluid and ascites. Abdominal viscera look normal, appendix was inflamed, and there is no gangrene or appendicular abscess. Patient postoperative period was totally uneventful except only the pain, and I discharged the patient on second postoperative day from the hospital. On fourth postoperative day, I got a phone call from the patient parents, and he complained the scutal swelling. So I clinically examined the patient. It was the edema of the scutum, but there is no symptom of acute scutum. And then I did the ultrasonography of scrotum and whole abdomen, and there is a huge ascites with scrotal edema. And I investigate thoroughly, including total blood count, thyroid function, serum electrolytes, serum amylase, protein profile, renal function, liver function, and X-ray of chest X and X-ray KOB. But all the hematological, biochemical, and radiological investigation were within the normal limit. So I reviewed the video clip and I discussed the matter with my senior surgeon, and of course I assured the patient parents. So I start to searching the literature. First one was this is a German literature, management of more frequent complication of laparoscopic surgery, minimally invasive or always open surgery, and a nationwide analysis of laparoscopic complication. I found that the intraoperative and postoperative complication of minimal access surgery is only 0.1 to 5% of intervention, depending on the complexity of the intervention. Then I found one literature published in 2001, postoperative ascites developing after laparoscopic surgery can become a difficult diagnostic dilemma. Postoperative ascites is a rare complication of laparoscopic surgery. Life-threatening and serious complications such as unrecognized bowel urinary tract injury should be excluded promptly to avoid the mortality and morbidity. Occasionally, no definitive cause can be identified after an extensive diagnostic case. In such case, we can level of idiopathic. And so in literature review, we found that some causes of ascites after laparoscopic surgery. This is bowel injury. It may be urinary tract injury. It may be acute pancreatitis, or chylous ascites may be developed after extensive dissection of retroperitoneal region. And in literature review, I found only one case report that is published in 2014 after laparoscopic appendicectomy. That is post-operative ascites of unknown origin following laparoscopic appendicectomy, an unusual complication of laparoscopic surgery by Mr. Ferretis. And she was a 25 years old Caucasian female admitted with clinical feature of acute appendicitis, and she had a comorbidity of sciatica and cervical intraepithelial neoplasm. And after all investigation, working diagnosis was acute appendicitis, and patient underwent an emergency laparoscopic appendicectomy, and patient developed ascites and no cause was found. This is the only case report I found in literature search, ascites after appendicectomy of unknown origin, in where cause cannot be identified. But there are some other literature, maximum from gynecological procedure. After gynecological procedure, 1 or 2 I found after laparoscopic cholecystectomy, ascites was developed. So my case, Master Doha, was operated for acute appendicitis. Her surgery was uneventful and almost bloodless because I use electrosurgical instrument for my surgery, and patient did not develop any feature of peritonitis. Her bladder and bowel habit was also normal. He was afebrile, asymptomatic, and clinically after all investigation, no cause can be identified. I cannot identify any cause. So it is a case of idiopathic ascites after laparoscopic procedure. And by the grace of Almighty Allah, patient improved within 2 weeks, and his total ascites was gone. And I treated the patient conservatively. So postoperative ascites of unknown origin after laparoscopic surgery is very rare complication. Patient should be examined and investigate promptly to identify the cause and monitor in order to find out any iatrogenic visceral injury during the laparoscopic procedure. My patient is now very fine and well. And so thank you everybody. Thank you for patience hearing. সবাইকে বিজয় দিবসের শুভেচ্ছা।
Thank you, Lieutenant Colonel Nasir, for sharing your unique experience, and thank you for finishing on time. Now our next speaker will be Dr. Boktiar Ahmed, a young surgeon from Bardem Hospital. His paper is